Hi, I'm Dr. Eric Goldstein, and we're going to get started. I am one of the gastroenterologists at New York Gastroenterology Associates. We are a group of 15 gastroenterologists and one of the premier private practice groups in New York City and the surrounding areas. We provide consultations and perform diagnostic services and therapeutic services for a very wide variety of GI conditions. And we have multiple locations throughout the city. Tonight, I have the distinct pleasure to introduce my friend and colleague, Dr. Yevgenia Pashinsky. Dr. Pashinsky is a fabulous gastroenterologist, and I think we're all going to learn an awful lot tonight about constipation from her. She is a Mount Sinai born and bred alumna and been with us for quite a long time. And again, I'm really looking forward to the talk, and I hope that you will also. Before I turn the microphone over to Dr. Pashinsky, we have a few housekeeping matters. The webinar will be recorded and posted to our NYGA website. You'll also be able to find previous webinars there as well. Please use the QA function to submit questions, which myself and some of the other panelists will be able to answer during the talk. And some of the more important or more popular questions we'll save for a live Q&A question session afterwards. Without further ado, let me again introduce Dr. Pashinsky.
Hello, everyone, and good evening, and happy summer. I thought I was going to be saying happy spring, but I think spring has sprung, and hopefully everybody got to enjoy a little bit of sunshine. As a disclaimer, I am technologically terrible even a year into the pandemic, so please excuse any glitches on my behalf. And this hasn't gotten any less weird, although it's become quite comfortable to talk to all my patients on Zoom. It's certainly weird to talk to my own computer all by myself in my office. So without further ado, we're going to get to a topic that is not always easy to talk about and is certainly not always easy to live with, and try to explore everything you ever wanted to know about constipation. So can't, by the way, take full credit for the awesome title. I did borrow a little of it from some of my esteemed colleagues in Texas. So what are we covering today? We're going to be discussing what constipation is, why it develops for some of us, and what testing may be useful in evaluating your constipation, as well as what treatment options are available for you to feel better. Before we could get onto the constipation part, we have to take a little detour for an anatomy and physiology lesson. So starting from the beginning, we like to confuse things a whole lot in medicine. So we like to name a lot of things, strange names that don't always make sense. So very importantly, the colon and the large intestine are one and the same thing. It is the very last part of our digestive system, and it makes about 1/5 of it, or about 5 feet. The colon has a lot of different parts to it, and I'm sure you've heard different parts referred to by your doctors. So there is the very beginning of the colon, or the cecum, that's where the appendix comes off. There is the ascending colon, or right colon, because it's on the right side of your body. The transverse colon, which kind of sits right underneath the upper part of your abdomen. The left or descending colon, which is on the left side of your body. The sigmoid colon, because it's got this little S shape. And then the rectum, which is where everything is stored for elimination. The colon itself has a little bit of this sort of pleated appearance with these little kind of sacs called haustra. So the reason this happens is, I think the best analogy is a long sleeve that has a ribbon sewn on the outside of it that is shorter than the sleeve, and hence it kind of pleats it onto it. So that little ribbon is a group of muscles called the teniae coli, which kind of pleat the colon to make these little kind of subcompartments. Now, the wall of the colon is, pretty complex as well. It's quite thin, but it is made up of a lot of different layers. We have multiple layers of muscle that run both longitudinally and in a circumferential way. So you have both the length of the colon and the circumference of it. We have, a couple of other different layers, and very importantly, the mucosa, which includes the colonic crypts, which kind of look like little little test tubes and have little openings in the middle and are responsible for mucus secretion. So I'm sure you've heard a lot of these terms over the years talking to your docs, and now you guys are going to be experts in anatomy and physiology. So what does the colon actually do? So this schematic is made a little blurry almost on purpose because it's a little overwhelming. But what the most important part of what we cover for this is the colon has three primary functions. It is about absorbing water and electrolytes, producing and absorbing vitamins, and propelling the feces and waste towards the rectum. So by the time that waste makes it to the colon, about 90% of the water has already been absorbed by your small intestine. So roughly 45 ounces, or about 1.5 liters in metric terms, will reach the colon on any given day. So the ascending colon, or that right colon, the beginning that we talked about, is what's responsible for sort of kind of absorbing water, and the bacteria, which you guys heard a lot about in Tamara's talk, which is phenomenal. And if you haven't, you should absolutely check it out. It's on the website. It's all about the microbiome. So the bacteria that live here are responsible for a lot of different functions. And they produce multiple vitamins by the process of fermentation. So this includes vitamin K, a couple of the B vitamins like thiamine, riboflavin, and biotin. They also ferment certain carbohydrates in order to produce short-chain fatty acids. And the bacterial breakdown of fiber that comes into the colon actually produces nourishment for the bacteria, and then produces nourishment for the cells of the colon in turn. So it's a very important ecosystem. The vitamin aspect of what the colon can do is really important, particularly at times where the intake of these vitamins may be low for a particular individual. By the time things are sort of making it to the other side of the colon, this is more of the storage and solidification of stool. And the sigmoid colon is what propels the stool kind of with forceful contractions down towards the rectum. This is where things are stored for the process of elimination. So now we know, kind of the general gist, but, how does this colon movement even happen? And what's the difference between different people and different times? So there are two types of contractions that happen in one's colon. There are the low amplitude haustral contractions, and there are the high amplitude or mass movement contractions. So low amplitude is kind of what it sounds like. They're not very strong, and they occur very frequently. So this happens more than 100 times a day easily. This is the kind of contraction that serves to move fluid contents across, and this is what's responsible for flatus or gas passing. So this is why people may pass gas multiple times a day, but don't necessarily have stool quite as many times. The ones that are responsible for movement of stool are the high amplitude contractions, and these actually only happen just a few times a day, maybe like 6 times at most, which is why we only have the urge to have a bowel movement at most a couple of times. These are much more forceful contractions as well, and these are the ones that you may feel very differently than the ones that are the haustral ones. So very importantly, as a kind of pitch for later, serotonin and serotonin receptors are very important in colon contractions, and they enhance colonic contractions. And yes, it is that very same serotonin that is responsible for mood, anxiety, depression. So lots of brain gut stuff here. The normal transit time from your mouth to your colon is roughly in the 6-hour range for solid food. And the transit time through the colon is highly varied and can range anywhere from 10 hours to 40 hours, depending on who you are. So this range of normal is different as every person. So now that we know what the colon is and what the colon does and what it looks like, we could start talking about what can go wrong. So constipation is incredibly, incredibly common, and it affects roughly 30% of the US population. It is much more likely to happen in those who are elderly, those who are female, and those of lower socioeconomic status. A staggering $820 million are spent every single year on over-the-counter laxatives alone. And we very well know that having constipation is associated with a higher prevalence of psychological distress and a very much a reduced health quality of life, which is a very important thing to take note of. So The big problem is constipation is often incredibly misunderstood and miscommunicated. And I bet that everybody on this webinar is probably identifying with one or two of these and not necessarily all of them, because constipation really does mean very different things to different people. So for some people, it just means they have very hard stools. They might go every day even, but they're just harder than they would like them to be. Others, it's an issue of not going every day, whether your stool is normal or not. It just doesn't feel right. Furthermore, people could be going every day, but just exerting entirely more force than they would like to get the job done. There are those who go maybe even a couple of times a day, but they feel incomplete every time it happens. Very, very often, the only presenting complaint that I really have for patients presenting with constipation is bloating. It's just a sensation of being full and uncomfortable. And then there's obviously patients who will have manual maneuvers to try to extract stool from their rectum on a regular basis. This could be a combination of more than one of these. So kind of gets a little confusing. So when you come into your doctor's office and say, I feel like I'm constipated, that could mean a lot of different things. So it is extremely important to get on the same page with your medical provider in order to get the right care. So things that are very important to share. I know my patients all know the Bristol stool chart very well because they get shown this chart basically every visit they're here. But important things to note for your visits and to discuss with your doctor are, when was the last time that you felt your normal self and you had your normal bowel function? And what was that even like? So we can understand how long has this issue been going on and what are we aiming for, right? So if your normal regular bowel function used to be, I don't know, 3 times a week, now you're going once a week, that's very different than somebody who used to go twice a day and now is going once a week. We obviously have to know how often you're now moving your bowels, how the consistency of them is, and this is where this chart sort of comes in, so you could identify it and just make it very clear. How easy or difficult is it for you to evacuate the stool? Do you do anything to help that along, whether it be positioning, using your hand, etc. We absolutely, positively have to know a full list of everything that you're taking, including the supplements, the vitamins, over-the-counter meds, and the prescription ones, of course. And also if any of these have recently changed, because as you will see later on, there could be a huge contribution from these to your symptoms. It is very important for us to know whether you've had any issues with your bladder or any urinary dysfunction, as well as sexual dysfunction of any kind, and if you've developed any neurological symptoms to go along with what's happening with your bowels, such as numbness, tingling, or tremor. So, sometimes my patients come in and they say, I show them the Bristol stool chart and they just don't seem to identify with any one of these. They say, I don't have any of those. Because sometimes the explanations are confusing and doesn't quite make sense. So feel free to get creative and use whatever terminology that you want in order to communicate what you need to communicate. And if you open Google's Pandora's box, you will find quite a few of these. I actually had to stop myself because I was putting too many on this because I found them to be entertaining. I know some people find them to be a little bit on the gross side. So how do we actually define constipation as physicians? So this is the Rome 4 criteria for functional constipation. And I know Dr. Frater, in her excellent IBS talk, also available on our website, talked a lot about the Rome criteria for IBS. Kind of the Rome committee, in a way, is it's a bunch of expert physicians who get together in Rome every couple of years and come up with a more structured way for us to treat our patients, particularly those who have conditions that have a lot of subjective parts to them and are sometimes difficult to define and hone in on. So the Rome 4, which is the latest of these, finally moved past simply focusing on stool frequency as the main issue. And at this point, the definition is, you have to have at least 2 of these, which is, straining, having lumpy stools, feeling incompletely evacuated, feeling like there's a blockage, and using manual maneuvers. You must have loose stools extremely rarely without the use of a laxative, and you have to have insufficient criteria for irritable bowel. And obviously the big difference here is, abdominal pain is a major hallmark of irritable bowel. what you'll see and what I'll keep honing in on over and over is that all of these things are really part of a continuum. It's not isolated issues, each in its specific box. You could have more than one version of this. You could have more than one of the etiologies that we're going to be talking about. They often do overlap quite a bit. So how do we think about our patients and how do we try to figure out what's going on when they come into our office? So we kind of have to break things down into categories in our mind. And kind of the four big categories that I happen to think about when I see patients is, acute constipation, chronic constipation, primary constipation, or secondary constipation. So acute constipation means this is something fairly short-lived. This is kind of something recent. And it is often a very transient, pretty straightforward issue that is usually related to stressors, a change in routine, a change in exercise or activity, immobilization after surgery, potentially taking some sort of new medications, et cetera. This is usually pretty easily remedied by over-the-counter medications, some dietary changes, and doesn't really, cause too much problems. Now, chronic constipation, on the other hand, is something that has been happening for at least 3 months or more. So we're going to kind of move on into the chronic. And so out of the chronic, we're going to talk about the difference between the primary versus the secondary. So we'll get secondary out of the way first, because this is kind of one of those, it's not your colon's fault, constipation. This is something that is happening elsewhere in your body or affecting your body in a way that's causing you to be constipated, but not necessarily a problem with what your colon intrinsically does. So many metabolic disorders could be associated with constipation. This includes diabetes, hypoactive thyroid, high calcium level, which can happen due to certain disorders, pregnancy, and very much eating disorders, particularly anorexia. Many medications contribute to constipation or cause it. Obviously, opioids are well known to, and they're sort of front and center. But this also includes many blood pressure medications, such as calcium channel blockers and beta blockers. This includes a wide variety of antidepressants, antipsychotics, over-the-counter antihistamines that I'm sure we're all kind of taking right now because of the crazy pollen this season, calcium supplements, iron supplements, aluminum. The list could go on and on and on, and just about anything could be contributing. So hence what we talked about in the communication slide, you really need to be very clear with your doctor about everything you're taking and for how long. Many neurologic disorders are major contributors to constipation. In particular, this is Parkinson's, injuries to the spinal cord, and multiple sclerosis. There's actually interesting data most recently that constipation may precede diagnosis of Parkinson's for some people, and they're trying to figure out ways to figure out how to catch it earlier. And I know that last one seems like it kind of is your colon's fault, but colon cancer, strictures, et cetera, are kind of not a problem with colon function. It's kind of more of a structural issue that kind of put into the secondary category that's addressed a little bit different. So moving into the primary constipation. So now we're dealing with the chronic issues of things that are related to your colon itself. So there's kind of four broad categories that we look at. There's IBS-C, which Dr. Fredo discussed excellently. I don't know if that's a real word. There is the normal transit constipation, or the most common kind, which is sort of the colon's doing its job, but not quite all the way. There is the slow transit constipation, which means the colon's really not sort of doing its job. And this could come both from nerve-related issues or muscle-related issues. Those are what those terms mean. And then there's the outlet dysfunction, which means things kind of can get out the door. And it kind of gives you the general breakdown of how often each of these things are the issue. As I'll talk about a little bit later, outlet dysfunction is probably much more common than this. This is kind of a schematic to show us how much of a continuum this really is, and how much overlap we tend to see between all of these disorders. The main factors that are involved in all of this, and the main combinations of things, this is really an issue of brain-gut interaction, visceral hypersensitivity, the microbiome, sensory function, motor function, and mucosal immunity. All of these things do play a role in all of these disorders. So very importantly, as we go along through this, the three main components of defecation are contraction, which is peristalsis or movement, secretion, which is kind of the mucus that your colon produces, and pelvic floor function. And just remember, we're dealing with a continuum, and you may not fit into one particular category. So let's talk about transit. So we talked about those contractions before and how the colon is supposed to work. So what does normal transit and slow transit actually mean? So normal transit is the most common subtype of constipation, accounting for upwards of 59% of all people who present constipated. It is generally, this is the simple constipation. This is generally an issue of not enough fiber or simply not enough food. It's kind of a nothing in, nothing out situation. There are some people that just have a high baseline stool burden. So even though they're emptying and their colon is pushing stuff along at the rate that it should, they're just creating more stool than it could keep up with. I'd like to point out very importantly, this is not ever an issue of just not drinking enough water. We'll talk about fiber in a minute, but this really has to be a balance of fiber and water. And it's not just, I'll just keep drinking water and all will change with this. Now, slow transit on the other side is a very different beast. This is actually a very small percentage of all constipation, but obviously pretty high percentage of what we do see in our practice and probably some of the patients that are currently attending this webinar. This is a dysfunction of smooth muscle activity in the colon. This is a dysfunction of colon-colon reflexes, neurotransmitters, and the activity of the colon pacemaker cells that kind of stimulate things to move. There is a decrease or absence of those high amplitude mass movement contractions that are supposed to be there. There is very much a blunted response to eating and to laxatives. So the eating response is something called the gastrocolic reflex, which is when your stomach kind of stretches with food. It's a signal for your colon to start moving things along. So in these individuals, this doesn't really happen. And the laxative response is not really as robust as it should be. There's also a lot less, or absent sleep-wake motor activity, because we do have a significant amount of variation in what your body does when you're asleep versus when you're awake. And there is obviously now evidence that there is an altered microbiome that could potentially be responsible to some degree, because we have found over and over that methanogenic flora, or bacteria that produce methane, are just much more common in those individuals, both in children and adults who happen to present with constipation. So now let's talk about this pelvic floor, this door that I've mentioned a couple of times that a lot of people don't really know very much about, but is actually now coming into the news a little bit more, and people are talking about it. Seen multiple articles most recently. So what does this pelvic floor thing do? So obviously, it keeps us continent, both urine and fecal matter. It gives us stability in order to have the spine and the pelvis be properly aligned. It supports all of our abdominal and pelvic organs. It is a very important role in sexual function, and it has some protective reflexes that go along with it. So what makes up this door and this pelvic floor? So this is a cross-section of a female pelvis. And what you're seeing here, this is the sigmoid coming into the rectum, and this is the anal canal. This is the uterus and the vagina, the bladder, and the urethra. So the pelvic floor is kind of all of the muscles that are all down here. And you could see them on this schematic a little bit more. But more than just all of these muscles that are kind of the gatekeepers at the bottom, the multifidus muscles of the back are part of your pelvic floor, and the transverse abdominis muscles of your abdomen are part of your pelvic floor. And all of these things very much have to coordinate in order for you to be able to have a successful bowel movement. And these are things that we don't really think about when we're thinking about going to the bathroom. But, because it seems like a very simple concept that you shouldn't have to think about very much. But anatomically, and physiologically, the filling of the rectum, so once there's stool in here, it initiates a reflex arc that causes relaxation of your internal anal sphincter. You have two of them. There's an internal and external. I know they look about the same here. And that causes the relaxation of your pelvic floor muscles, which opens up what's called the rectoanal angle and relaxes your external sphincter, along with a contraction of your diaphragm, which is another part of it that I forgot to mention, and your abdominals. So outlet issues, so issues with this whole arc, are associated with probably about 50% of all people presenting with constipation, and it's at least 2/3 of those who are presenting with difficult defecation as their primary complaint. There are multiple types of pelvic floor dysfunction, and it's kind of the difference in what you're able to do. It's about, you don't have to know any of the stuff, and this is what we're here for. But this really has to do with your ability to push, relax, and coordinate things. And there's different kind of ways that could not go quite right. So very importantly, also, there are certain structural components that could be, part of pelvic floor dysfunction, such as a rectocele. Some people with constipation have what's called solitary rectal ulcer syndrome, which is kind of an ulceration of the rectum from impacted stool that could sort of be part of a pelvic floor disorder, but this is kind of what we're focusing on right now. This very, very often overlaps with both slow and normal transit constipation. So treating the whole person is the really important part here. So I'm sure all of my patients on this webinar know this analogy very well. It's one of my favorites. It's the toothpaste analogy. And the way I describe it is that if you're trying to get toothpaste out of a toothpaste container, you need to be able to open the cap and squeeze that tube. If that cap is closed, you could squeeze that tube until you turn blue. You're not really going to get anything out of it. Conversely, if your cap is open, but instead of squeezing the tube, you're trying to squeeze the tip of the cap, it's also not going to be very effective. So like if you think of your colon as your tube and your pelvic floor as your cap, and if those two things are not coordinating with one another, you're going to be struggling and having a hard time. And very importantly, and I'll talk about things in a minute, but fiber is one of those things that will absolutely worsen those patients who have pelvic floor dysfunction. So how do we figure out what kind of constipation you have? Obviously, we talk to you and we do a physical exam. Very importantly, this should include a rectal exam by your physician to test for that pelvic floor issue that we just discussed. And just doing an exam by one of your physicians is actually known to be 75% sensitive and 87% specific for pelvic floor dysfunction, though it doesn't always tell us the whole picture. We usually run some blood tests, particularly looking at calcium levels, as we discussed, that could be an issue. Thyroid levels, obviously making sure that you don't have anemia or kind of any other major abnormalities. Now, other things that we'll discuss in greater detail. We do Xrays. We do pelvic ultrasounds in our female patients to make sure there's no issues such as fibroids, ovarian cysts, or kind of any other worse scenarios that could be part of this. We will talk about enorectal manometry testing, MRI difficulty testing, and the 3 different transit studies that we have. And I think colonoscopy is the one that I think most of you guys are quite familiar with. And that is something that we obviously reserve for anybody with new onset constipation who is older or due for an exam or kind of has any of the alarming symptoms that we'll cover in a little bit. So let's start with X-rays. So now that you guys are experts in colon anatomy, I think this will make sense. Don't be overwhelmed. So these are 2 of my patients who presented with very, they're different ages. They presented with very different complaints. One of them was just a little bloated. She was having absolutely normal bowel movements every single day, but she just felt bloated and not right. The other one was kind of not going daily and having a little bit of pebbles here and there and felt backed up because of that. As you can see, so on an X-ray, white is kind of the densest, which is bone. So you see the skeleton here. Black is air, which is the least dense. And what you see here in the shape of the colon that you guys know, the ascending, transverse, descending, sigmoid, and rectum, you're seeing all of this fuzzy stuff. That fuzzy stuff is stool. So quite constipated, and same goes for this person. So even though people presented with pretty different complaints and have very different bowel function, they are both extremely constipated. This is a very simple test that you could easily get, on any given day when you see a physician, and it can give us a nice baseline understanding of what you walk around with on a daily basis and why you feel the way that you feel. So moving on to enorectal manometry. So this is one of the tests of the pelvic floor. And the way it works is that a small catheter with a deflated balloon is inserted rectally, and the balloon is inflated from the outside. And you are communicating, you're awake for this, you're communicating with your physician about when you sense the balloon. And then there are multiple sensors that are on the balloons, sorry, on the sensor. I lost my train of thought for a second. That can measure force of contraction. So you are instructed to do certain maneuvers like pushing, squeezing, etc., and we're able to measure if you're doing this correctly or not. So these are this is what we get as a result, and these are pressure tracings. You absolutely don't need to know to understand it, but this is basically what we see in a normal patient who is able to relax. So red means very tense. So this is somebody who's able to relax in order to be able to defecate. This person is actually tensing when they're trying to defecate. So it gives us a really good idea of what's happening with that. So MRI difficography is another test of pelvic floor function. And this is this is dynamic imaging during a stimulated defecation. So this is not a fun test. This is where you are given sort of an enema of contrast for an MRI. And while you're in the MRI machine, you're basically doing bearing down and trying to simulate defecation. And they're able to see exactly what is happening in your pelvis when you do this. So they're able to see if the rectum is bowing out incorrectly, if you're actually tensing things up and pulling things in different directions. And it really makes us understand that pelvic component quite a bit more. So motility testing. So we check the pelvic floor. So how do we know if the colon is doing its movement correctly? So a very simple test for this is the Sitzmark study. And this is a little tiny capsule. It's not very big. It's about the size of a vitamin. It's a little gel cap that has tiny little plastic rings in it. There's 24 rings in a standard Sitzmark, and they are visible on an X-ray. So generally, there's a protocol that is day 3 and day 5. So you swallow the capsule. The plastic, kind of gel cap stuff melts away, just like it would for any. And the little rings travel through the colon, and we're able to see them on an X-ray. So this is able to give us an idea of how quickly things move through the colon and how things are distributed, as well as get us to understand if you're walking around with entirely too much stool. So, for example, if at day 3, this is what your Sitzmark looks like, AKA all of them are sitting in the rectum. This makes us think about a pelvic floor disorder and an outlet disorder, about things not getting out the door. If we're seeing this kind of scenario at day 5, so the markers are everywhere, that makes us think about a colon that really doesn't contract whatsoever. So you're getting these little movements back and forth in a way, but nothing really propagates. So, kind of another very simple test with a lot of useful information. So this is what it looks like on a patient who is also very constipated, as you can see. But this is kind of, the markers are, they're making it in a coordinated way down the left side, but not necessarily fast enough. Sort of the fancier, more sophisticated versions of motility testing include a nuclear transenteric study. So this is a bit laborious because you have to come to the hospital for about 4 days in a row to get the study done. But it is considered currently the gold standard way to test motility. And this tests everything from your mouth, to the anus. So we test the motility of your stomach, your small intestine, and your colon. And what happens is you basically ingest radioactive food at the hospital radiology department. You don't glow in the dark. It doesn't taste any weirder. It just really tastes like crappy hospital food. It's usually toast, jam, and egg beaters, a small quantity, and they emit a signal. So they're able to see how this transitions through your intestinal system. And as you can see, this is sort of over a certain amount of time, this is tracing out the shape of the colon. So there are obviously metrics that the radiologists give us that let us know if that is happening at the right pace or not. And last but not least, the newest kid on the block is the smart pill. This is the new cool thing to do, but it tells us a lot of pretty useful information. So the smart pill is exactly what it sounds like. It is a small capsule. I know it looks a little bigger than small, but generally people have very much issue swallowing it. It has sensors on it that monitor pressure, temperature, and pH. So the capsule knows where it is in your digestive system as it travels through. So this is something that you would swallow at our office and wear a little kind of a recording device that it sends its signal to. And then at the end, the result that we get looks something like this. And I know that does not look like English or making any sense, but we're able to tell how long this little device spent in each part of your intestinal system. It also gives us some other useful information like stomach pH, as well as the pressure in your ileocecal valve, which is associated with some other gastrointestinal disorders that are not part of the scope of this talk. So we just did a whole lot of testing and implemented just about everything we have in our book. So, what do we actually do with all this information? And what we do and what we strive to do and hope to do is provide you with an individualized treatment that fits your particular issue. Because as you saw, everybody's issues can be quite a bit different, and there's really no one size fits all approach. Generally, outside of somebody having a very glaring, very clear pelvic floor disorder, or a complete failure to 3 laxatives before even coming to see us, the right approach for somebody presenting with constipation for the first time is lifestyle and diet, which obviously will include plenty of hydration in balance with fiber, not just one or the other. Healthy eating, getting sleep, because the sleep-wake cycle is very important in your gut function, getting plenty of movement and exercise, because guess what? When you don't move, neither does your colon. And this is why we see so much constipation in hospitalized patients who are immobilized, as well as the tremendous amount of constipation that we all saw during the COVID pandemic when everybody was sort of immobilized on their couch. So let's talk about some of the treatments a little bit in greater detail. So this looks a little bit like a fast food menu because it's kind of meant to. This may be something that you may need more than one category of these things. You may need to try one after the other, and we'll talk about each one, what it means, and what it does for your body. So, my guess is that if you're on this webinar, it's a good chance that the healthy lifestyle that we just talked about didn't quite cut it, and you need a little more help. So that could come in a lot of different varieties. So talking about fiber again, basically what fiber is a poorly digested complex carbohydrate that is able to bulk our stool as well as draw fluid into the stool residue. It also undergoes partial fermentation in its own right if it's naturally occurring, and it produces some short-chain fatty acids as well as gases like hydrogen and methane. It serves to increase the weight of stool as well as accelerate colonic transit and changes the colonic pH. The goal for most adults is somewhere in the 25 to 35 range. It's sort of a little bit lower for women, 20 to 25, about 30 to 35 for men. And we recommend gradually increasing the fiber as opposed to, increasing it immediately, because gas and bloating are a real true side effect. This is the most efficient treatment for those with normal transit constipation as opposed to the other types. So those with pelvic floor dysfunction and slow transit constipation are more than likely to feel worse when they try fiber. There are different types of fiber available. I'm sure all of you guys have seen some of these guys, and some of them are naturally occurring. So this would be like the psyllium or metamucil type, the wheat dextrin like benefiber, and they also have the benefit of helping to lower one's cholesterol in the process. But because they're fermentable, once again, gas bloat. Methylcellulose or citrusel is a synthetic fiber, but it is also purely soluble and does not undergo fermentation, which means it tends to be extremely well tolerated from the gas bloating perspective. And remember, hydration is extremely important when you're working with fiber, because otherwise you get sort of cement in your intestines as opposed to anything else. Just as a plug, flexing fiber to your advantage, a whole talk on fiber is coming up in the coming months by one of our very talented new dietitians. So watch out for that if you'd like to know more. So outside of fiber, we're going to move on to kind of a mix of both over-the-counter and prescription options. So what are surfactants or stool softeners? So this would be things like docusate or colace that I think some of you are familiar with, as well as mineral oil. So what these guys do is they make the stool a little bit softer and more slippery. Colace does it by lowering the surface tension of stool, allowing more water to come into it. Mineral oil just penetrates the stool and softens it and makes it obviously much more slippery, but not really meant to be used chronically because it could interfere with absorption. These guys are not actually laxatives. These are just, they just serve to soften the stool that is already there, as opposed to actually help anything move. So this might be appropriate for somebody that goes every day, but just the stool is a little bit harder than they would like it to be, and that could be a good solution. Osmotic laxatives are probably the most common and the most utilized type, and these are the guys that are either saline or hyperosmolar. These are fancy terms for saying they create a gradient that brings water into the bowel lumen. And this causes obviously softening of stool and a kind of propulsory effect in that way. This includes the most common ones that you'll see is Miralax or polyethylene glycol, the various versions of magnesium that are out there, whether it's citrate or oxide, so milk of magnesium, mag citrate, pill versions of these, as well as lactulose, sorbitol, etc. The only one that really, has any kind of warnings on it would be that high dose magnesium cannot be used for patients who have any kidney disease because it can really cause some issues with their kidney function. So moving on to some prescription things. So this is all kind of still in very much the over-the-counter category that we're in. And now we're going to move on to some prescription options. So secretagogues are drugs that you might have heard of as Amitiza, or lubiprostone, linaclotide or Linzess, or pleconite or Trulance. So these are medications that are act within the lumen of the colon and change kind of the function of some ion channels that then promote colonic secretion of fluid into the lumen and also have some enhancement of transit that way. So this may be a good option for some people with slow transit, and a lot of them are also approved for irritable bowel with constipation. Now, moving on to a very important category, the stimulants. So stimulants are things that are known as, some names to throw out are Senna, X-Lax, Swisscris, Cascara, Dulcolax. These are the guys that have a bad rep because there's a lot of misinformation out there about the terrible things that they could do to your colon. These are the ones that work by increasing colonic contractions. So this is why they can be cramping. These are the ones that kind of make those high amplitude contractions work and move stool along very effectively. There's absolutely, positively zero evidence whatsoever that any of these medications, even when used chronically, cause any colon damage or cathartic colon or dependence in themselves. So that is a misinformation a lot of my patients come with, and they're very scared of taking them, even though they're effective and really help them feel much better. So love this little picture. Just a plug for coffee, which is a stimulant laxative because not the caffeine, as everybody often thinks. It has to do with a component in coffee called cholinergic acid, which enhances colonic contraction. So it is a very effective way to start your day. And we often kind of utilize it, ask people to start introducing it. Decaf is totally fine because it's not the caffeine. So it's a tricky little stimulant. The next category of medications that we have are the agents that work by using serotonin receptors. So this is what we talked about before. Serotonin, that same one that controls mood, also controls colonic contractions quite a bit, as well as colon sensitivity. So this is a big component in pain and visceral sensitivity for a lot of people. So this is one of the newer drugs that we have around called Motegrity or Prucalopride. It's not actually that new. It's just fairly new to the United States. It's been in use and highly effective in many countries for a long time now. And it is a very highly selective serotonin 4 receptor agonist, so it stimulates it, and very effective for slow transit constipation. The older version of this that we used to have on the market, then we lost it, then we brought it back, is something called Zelnorm or Tegaserod, which is less selective, and that's why it has some limitations on its use in certain patients. And very importantly, If you have a pelvic floor disorder as any component of your constipation, what will really help you is pelvic floor physical therapy. It's not going to be a lot of this stuff. And I see this all the time. People come to me saying, well, I'm on that, Linzess, it works. And the way it works is that it basically gives me explosive diarrhea every morning, but then I'm done and I feel okay. And that's because it's sort of trying to overcome that problem with the exit door and kind of basically slamming through it to provide relief as opposed to actually engaging it. And pelvic floor therapy sounds very weird to many patients when I first bring it up, but it is essentially retraining. It's one of my patients called it potty training. It is retraining your muscles to do what they're meant to do in order to produce effective bowel movements. And this is where that last category of rectal suppositories, rectal treatments, so this would be suppositories and enemas, and their role. Enemas are always a very useful way to get immediate relief for a lot of patients because it sort of unplugs, uncorks, whatever you want to call it, but it allows everything to just be brought down as opposed to trying to push it all from the top with laxatives, which may take many, many hours to work. This is kind of the thing that will work immediately. And for patients who have yet to engage in meaningful pelvic floor therapy, suppositories may be a very good treatment to kind of help stimulate and overcome this problem. So that's a whole lot of information and a whole lot of treatments. And when do we have to think about things other than just constipation? When is it not just I'm constipated, who cares? So these are all what we call alarm features. These are the reasons to immediately contact your doctor. These are reasons to undergo things like colonoscopy, et cetera. This is obviously seeing blood in the stool, regularly. This is people who are losing weight unintentionally, not the COVID-20 that some people want to lose. This is having abnormal blood work with your primary doctor, showing that maybe you're anemic. Any time that there's a sensation of something prolapsing or having tissue that you feel is protruding from your anal canal. Those who have significant ongoing abdominal pain related to this, not just IBS-C version that comes and goes every so often. Any association, obviously, with nausea, vomiting, or fever as part of your problem. Anytime symptoms wake you from sleep, we consider that very much an alarm symptom. And obviously, anyone with a personal or family history of concerning disorders, like whether it be celiac disease, colon cancer, or inflammatory bowel disease, which may make us think about your problem slightly differently. So we're basically almost at the conclusion of my talk with too much information. But the take-home points that I really want you guys to focus on is that constipation can mean very different things to different people. It can develop for many reasons that are both related to lifestyle, diet, and stem from underlying medical conditions. Various tests are here to help us better understand why someone is constipated in order to better guide your treatment. You don't have to live with constipation. We have a myriad of different treatment options available, and there's no one-size-fits-all approach. The goals of treatment may be very different to different individuals, and the goal of treatment is not necessarily to have a bowel movement every day. The goal of treatment is really to improve your quality of life, which are two different things. Very importantly, stress again, if you have any alarm symptoms, please see your doctor as soon as possible. Please talk to one of us. That's all I've got for today. Wishing everybody happy pooping.
Excellent job, Dr. Pashinsky. Thank you very much for these insights. It was definitely a great breadth and detail in the report, in this presentation, and I believe that everybody probably learned a lot. We do have a couple of questions that we will kind of come back to here. First and foremost, I know you just had a slide on it recently toward the end of the talk, but I do think it's extremely important to maybe go through again and touch on again. How long is too long to be constipated or suffer a change in bowels before seeking medical attention? And maybe, run through the red flags or the warning symptoms again might be very helpful.
Yeah, so If you have any of the red flag symptoms, it's sort of already too long, and you should have an immediate assessment. That is, anytime any of these options are present, it should be a sort of fairly immediate time to see your doctor. In any other instance, if none of these alarm features are present, it really is up to you as the patient as to, sort of how long do you want to keep putting up with this? And I think the sooner you see your physician, the better. Obviously, the short-lived stuff that we talked about, the acute versus chronic, something, kind of happened for 2 weeks, it passed, and you go back to your normal self. You took a little milk of magnesia and you forgot about it. That's probably not something to worry about. But if this is becoming a daily struggle and it's ongoing, and even if it's been a few weeks, it may be something to at least get your first evaluation started.
Terrific. Thank you. We got a lot of questions regarding over-the-counter therapies, specifically the safety, the frequency, and the duration that people can use them. And in particular, one issue that I see with my patients, I'm sure you do as well, is that many of the over-the-counter options specifically say use for 7 days or use for 14 days. And then they come to our office and we say, no, go ahead, use it forever. It's no problem. And everybody understandably gets very anxious about that. Could you comment a little bit on what is appropriate frequency, duration of some of the over-the-counter options that you discussed?
So the reasoning for, it's a great question. And yes, we all get this a lot, but it says I can only do 7 days. So I stopped and now I feel not so great again. So all of these medications, all of the over-the-counter options that are out there are incredibly safe. They're safe in the long term. They're safe to take forever. The reason for the labeling is because a lot of these drugs used to be by prescription only. And the pharmaceutical companies kind of don't really want the liability because they don't know. You may be somebody with alarm symptoms buying their medication. And if you just continue to take it without seeing a doctor, you may have an undiagnosed cancer or something else that's really not so great. So they want to make sure that before you continue taking something like this on a regular basis, that a doctor has looked at you and decided that it is totally safe, you don't have any alarm features, and you don't have to be concerned. So I still recommend obviously discussing with your doctor just to say, hey, this is working for me. Can I keep taking it? And make sure you're up to date with the appropriate testing that you maybe due for, and then there's no alarm symptoms that they are thinking of, but absolutely no harm in taking it long term.
Terrific, thank you. A corollary question that actually came up a couple of times here is the notion of laxative abuse. And I use Senna, it's working, am I abusing laxatives? I use Senna, it stopped working, am I abusing laxatives? And this may be a very important distinction to help clarify here.
Right. So as we mentioned, very importantly, these medications do not cause damage to your intestine. I think if you're using Senna and it is working just fine, it is just fine to keep taking it. I think if a medication that you were using is no longer working, this doesn't mean you're abusing a laxative. This means you should probably get an evaluation, kind of going right back to what we talked about so we could better understand, is there an issue with the pelvic floor? Is there an issue with motility? Is there a better medication that we can utilize for you? Is there some other underlying, disorder of the thyroid, et cetera, that we should be addressing? But it doesn't mean that you are abusing a laxative.
Thank you. You talked a bit about fiber and the recommendations for how much fiber we kind of should get on a general basis. But one question that was raised, are there foods which worsen constipation? Are there foods that slow gut motility, essentially?
So not exactly, but the lack of fiber in your diet, right? So we definitely, the balance of fiber and fluid in your diet will absolutely have an effect on your bowel function. Remember, those with slow transit constipation and pelvic floor dysfunction will actually feel worse with whether it's fiber supplements or super high fiber diets, because you're just sort of kind of, the way the analogy I use is that you're stuffing a sock with more and more stuff, but it's not getting moved anywhere. So it's just a sensation of fullness. So depending on the underlying nature of your constipation, excessive fiber may actually not feel good for a lot of people.
Terrific. In terms of fiber not feeling better, making people feel better, we did get a couple of questions or comments that our audience found it interesting that fiber was not actually a great idea in cases of pelvic floor dysfunction. Can you elaborate on that a little bit, please?
It usually just, what it does is it sort of creates a lot more stool buildup that one is unable to evacuate effectively until the pelvic floor dysfunction is addressed. So it's a lot more of that pressure coming from the top. It's got to be kind of just the right balance and not be overdone. There are some people with pelvic floor issues who have an even hard time passing gas, much less stool. So the more stool that you're creating in there may just lead to more issues for them. What do you think, Dr. Goldstein?
No, I completely agree. You're absolutely right that if you can't get things out, you're going to be more full. And that absolutely is spot on. One last question, and this is almost more of a educational / philosophical question that I've seen now come up a couple of times. Why is my colonoscopy normal if I'm so constipated?
Because,
can you comment a little on that?
Yes. So being constipated doesn't necessarily, well, it doesn't damage one's colon in any particular way, with the exception of that, rectal ulcer kind of situation. That's very rare. It's just a matter of how much your colon is storing and how much it is able to stretch. So it has nothing to do with the lining of your colon being inflamed, like we would see in colitis or Crohn's. Obviously, in the cases of a normal colonoscopy, it doesn't have to do with cancer or obstruction. It just has to do with how your colon functions rather than how it looks. And things could look very normal, but be very dysfunctional sometimes.
Terrific. I'm just really turning through here. Okay, wonderful. Thank you very much. I think we're just about out of time. There are still a few questions that have been sent here through electronically. I'm trying to get all of them answered. So Dr. Pashinsky, maybe before ending the webinar, we'll just leave it on for a few minutes so I can answer these questions, and we'll just all be muted and stare at blankness. But I want to thank everybody for attending. I hope that this was enjoyable, and it certainly was educational, and a big thank you to Dr. Pashinsky.
Thank you, Dr. Goldstein. And, we're here to answer questions. We're here to help with figuring out what you guys need. But I'm hoping that this gives you guys a framework for how to approach how you feel, how to approach discussions with your physician, and hopefully we get you all feeling better.